Hello everyone, this is Dr. Neelesh Singh, Senior Lecturer, Department of Periodontology, Babu Banarsi Das College of Dental Sciences. Today I am going to discuss a topic, desquamative gingivitis. Desquamative gingivitis. Before starting the chapter, we should understand what is desquamation. Desquamation, as the picture which I have shown in the slide suggests, it is peeling off. So what peels off is basically the epithelium. Okay. Now, condition was first reported in 1894, but the term was first coined in 1932 by the Prince. It describes a reaction characterized by intense erythema, desquamation, and ulceration of the free and attached gingiva. What we can find out here is the erythema, desquamation, and ulceration of the free and attached gingiva. Patients can be asymptomatic, but when symptomatic, their complaints range from mild burning sensation to the intense pain. Approximately 50% of the desquamative gingivitis cases are localized to gingiva, although patients can have the involvement of other sites and extraoral sites also. Coming on to the etiology and the diagnosis, initially the cause was unclear and with a variety of possibilities suggested because most cases were diagnosed in the women during the 4th and 5th decades of life, although the desquamative gingivitis was found in puberty also and 7th and 8th decade of the life, hormonal derangements was suspected. In 1960, McCarthy et al. Told that desquamative gingivitis was not a specific disease entity, but instead it is a gingival response associated with a variety of other disease conditions. This concept was supported by numerous immunological studies. Now, this immunological studies, what it is, I will explain later on. So, by clinical and various lab parameters, they have revealed that approximately 75% of these desquamative gingivitis cases are of dermatologic origin. Out of these, lichen planus, cicatricial pemphigoid, bullous pemphigoid, pemphigus vulgaris, linear IgA disease, dermatitis herpetiformis, lupus erythematosus, and chronic ulcerative stomatitis are the most common. But out of these also, the lichen planus and cicatricial pemphigoid forms 84% of the total desquamative gingivitis cases. So it is extremely important to ascertain the underlying disease responsible for desquamative gingivitis to establish an appropriate therapy, because the underlying disease has to be established to give a treatment, as the desquamative gingivitis is only a sign or a symptom, we can say. So, a thorough clinical history, clinical examination, histology, and immunological studies or immunofluorescence has to be established. So, coming on to first the clinical history. In the clinical history, what are the symptoms? Lesion onset, whether it has worsened with time, any detrimental habits in the patient, any previous treatment for the same condition. These questions has to be asked to the patient. Then come on to the clinical examination. In the clinical examination, the lesion distribution pattern is most important thing. Whether the lesion is focal or multifocal, or it is involving gingiva only, or it is involving other tissues of the oral cavity, or extraoral involvement is also there. One important sign is the Nikolsky sign, which is to rule out the vesiculobullous lesion. Now, what is Nikolsky sign? This is very important thing. Nikolsky sign is basically characterized by a blister formation or peeling of the skin when a lateral tangential force is applied on the surface of the skin or the mucosa. And if the vesiculobullous lesion is present, a blister will form or the epithelium or this mucosa will be peeling off. Then comes the histological examination. How we do it? We take a biopsy. And in these cases, especially the incisional biopsy is the best strategy. We take the tissue, we send to the lab, and lab process the tissue and make it ready for the microscopic examination. Microscopic findings like H&E findings and all those things we will discuss later. Now, coming on to the immunological study or the immunofluorescence. Now, what is immunofluorescence? It is a kind of diagnosis in which we assess what antibody is present in the tissue, because antibody type will determine the type of lesion. Now it is of two types, the direct immunofluorescence and the indirect immunofluorescence. For example, there is a bacterial cell and antigen is there on the bacterial cell wall. In the direct immunofluorescence, we mix this bacterial uh, cell with the fluorescently labeled antibacterial antibody. Now, the antibody is against the bacterial antigen and it is loaded with the fluorescent dye. Now, what happens is this antibody will bind to the antigen. For example, this, it is binding to the antigen here and will provide a light, that is fluorescence, and we will detect the antibody or the antigen. Now, in the second type, that is indirect immunofluorescence, the antibody which we are using is not fluorescently labeled. Basically, this is antibacterial antibody. It is not fluorescently labeled. We mix this antibody with the bacterial cell contents, and this antibody will bind to the antigen and forms a complex, but it cannot be seen because there is no fluorescence. After this step, we will add fluorescently labeled anti-rabbit antibody. Now here it has shown anti-rabbit antibody. We can use monkey and mouse for this purpose. Many studies use different animals for the production of this antibody. Now when this antibody is mixed with the content and it forms a bigger complex by binding the antibody which is attached already to the bacterial cell. So it forms a complex and provides a light. So it basically we are detecting the antibody which is present in the lesion site. Now this table is basically the management diagnostic table of variety of the diseases present in this column, which are all of dermatological origin. But the most important are the upper three. We will read only about this three, but a slight idea of every disease is should be there in the mind of a dentist or periodontologist. First is the pemphigus. Pemphigus basically represents as multiple erosions on the gingiva, and histologically we can see intraepithelial clefting. This small circles you can see in the epithelium. This is intraepithelial clefting, means space. Clefting means space. The basal cells have a characteristic tombstone appearance. The basal cells have a characteristic tombstone appearance, and there is also an acantholysis present. This is the acantholysis. Okay. Then in the indirect immunofluorescence, the intercellular antibodies IgG is seen in more than 90% of the cases. In the direct immunofluorescence, IgG is seen in as intercellular deposits. Both are same. Then we come on to the cicatricial pemphigoid and bullous pemphigoid. Now, cicatricial pemphigoid and bullous pemphigoid are almost same in the clinical features. Their epithelial or histological findings are also same. They are characterized by a subepithelial clefting. You remember in the pemphigus, I have told there is intraepithelial clefting, means the spaces will be present in the epithelium only. In this, the cicatricial and bullous pemphigoid, the spaces is present beneath the epithelium, or we can say in between the epithelium and the connective tissue. Here is the space. Above the space, this hole is the epithelium. Below this space, the hole is connective tissue, and this white portion is the cleft or the space. It is below epithelium, and hence it is subepithelial clefting. Now, if we consider that immunofluorescence and direct immunofluorescence, both are showing the same characteristics. I'm reading it. Linear deposits of C3 with or without IgG at the basement membrane zone in most of the cases. Both are same. IgG antibody milega in both of the cicatricial pemphigoid lesions and bullous pemphigoid lesions at the basement membrane. So how will we differentiate? We will differentiate with indirect immunofluorescence. In the indirect immunofluorescence, the basement membrane zone antibody IgG is seen only in the 10% cases, whereas in bullous pemphigoid it is seen in more than 70% of the cases. So hence we will find out which lesion is which. Then we come on to the management. And in the management part, we will only consider these three lesions which we have already read in the diagnostic part. First is the lichen planus. Lichen planus, we will get a diagnosis of lichen planus by all those things. Now, if it is asymptomatic, then there is no therapy needed, and periodic examination is made with the patient's consent. And if the diagnosis of the lichen planus reveals that it is symptomatic, then we have to first find out that either on the top of lichen planus candidiasis is present or not. And if it is present, if it is positive, we should use antifungals to the patient. Now, lichen planus can be either erosive and ulcerative. There are other forms of lichen planus, but these are the most common forms. Now, in both the cases, we'll give topical steroids. Now, if the topical steroids are given intralesional, the lesion can be resolved or not resolved. If there is resolved, then we have to reduce the treatment and consider monitoring of the patient time to time. Now, if the lesion doesn't resolve, we have to refer it to the dermatologist, and the dermatologist will give a combination of these drugs: retinoids, dapsone, cyclosporine, photophoresis, and systemic steroids are given. Now, coming on to the cicatricial pemphigoid, first we'll get the diagnosis of cicatricial pemphigoid, and if there is an eye involvement, we all know, or we should know, that cicatricial pemphigoid also involves the eye. There are certain lesions which are affecting the eyeball. So we have to refer to the ophthalmologist if they are present, and if they are not present, then also we should refer to the ophthalmologist to rule out any kind of progression. Then, if they are asymptomatic, we should do the plaque control and monitor. If there are mild and moderate symptoms, topical steroids. And if they are severe, then we have to refer again to the dermatologist. They will give prednisolone and dapsone. If there is no resolution, then these are the drug of choice: methotrexate, dapsone, cyclosporin, cyclophosphamide, and azathioprine. Then coming on to the pemphigus vulgaris. Now first we'll get the pemphigus vulgaris diagnosis. From there only we have to refer to the dermatologist, because this is a severe condition. The primary treatment is prednisolone, and the secondary treatments are azathioprine, cyclophosphamide, cyclosporine, methotrexate, gold, plasmapheresis, and phosphoresis. A very important point after reading all this detail is that dentist and the periodontologist can be the first person to detect a very life-threatening condition of the patient. And we need to refer to the more specialized care like dermatology, ophthalmology, and other specialized care, so that the patient should be in hands of the specialist before the condition worsens. This is all about the desquamative gingivitis. Mainly, the patient should be referred if the dentist feel that he or she cannot manage it alone. It is a teamwork. So this all things should be kept in the mind while doing any treatment regarding desquamative gingivitis lesion. Hope you understood the chapter. Thank you very much. Read well.